It's a great honor to be here today, and I want to congratulate you on putting together an absolutely outstanding conference. And it was really wonderful to see Peter again. Peter Slavin and I were 1 year apart, and I remember being an intern when he was a junior, and it was a real pleasure to work with him. Okay, so I've been asked to talk about the idea of making science a core component of value in healthcare. We may remember that there was a big debate about healthcare reform a couple of years ago, and at that time the Journal of Clinical Investigation put together a theme issue in which they invited a number of thought leaders to contribute brief essays about their perspectives. And one of the contributors was Betsy Nabel, who at that time was my supervisor. She was the director of NHLBI. And she wrote an essay in which she essentially said that you cannot talk about healthcare reform and you cannot talk about improving value in healthcare without talking about science. And specifically, she said that an insight which is obvious to those of us who engage in biomedical research, it's obvious that this is important, but this message is likely underappreciated by the American public. Biomedical research provides the basis for progress in health and healthcare. So what I thought I would do is go through some stories of where this idea was operative and where this idea was not, and see what we can learn from this. So, in October of 1940, Franklin Roosevelt was running for an unprecedented third term, and he must have been extraordinarily confident about his election chances because 1 week before Election Day, he took a detour to Bethesda, and he dedicated the new NIH campus. And at that time, he talked about the importance of a major national support for biomedical research. He referred to it as a critical form of national defense. Now, the picture on the right is what Roosevelt looked like 5 years later. This picture was actually taken 1 day before he died. You can see he looks rather haggard. At that time, he had a blood pressure of about 250 over 160. He had some of the best doctors in the country working with him who couldn't figure out what to do to help him get better. And the next day, he died of a hemorrhagic stroke. Could anyone imagine today a United States president dying of a hypertensive hemorrhagic stroke? So shortly after the NIH started at their Bethesda campus, they developed a strong interest in hypertension, and the NIH supported a number of critical research efforts. This is one. This is Irving Page, who was a researcher at Cleveland Clinic, where I previously was before. And this is a classic paper that was published in Science in 1965, in which he talked about the complex mosaic of neuroendocrine abnormalities that occurred in hypertension. So there were a variety of laboratories around the country that were doing path-breaking research trying to figure out what hypertension was all about. Now, at the same time, there was a path-mark epidemiologic study going on in Framingham. This started in 1948, so this is, again, shortly after the NIH got started in Bethesda. What happened here is that a group of investigators supported by the NIH brought together 5,000 adult residents of the town of Framingham and started a study which continues on to this day. The building over here on the left, this was the building in which the Framingham study was originally housed. It was an old Victorian mansion, and every time they ran the centrifuge, the whole building would shake. So they could only do it at night. So then they moved to the building over on the right. The building on the right was a building that previously had served as a convent. It was rented from the Archdiocese of Boston. Now they're in a beautiful office building. It's rather nondescript, but it's really gorgeous. Well, in 1961, Bill Cannell, who unfortunately died this past year, and his colleagues published one of the most important papers in biomedical research. This paper was called Factors of Risk in the Development of Coronary Heart Disease, 6-year follow-up experience from the Framingham Heart Study. This is the first time that the term risk factors was ever applied in clinical research. And in this study, in this paper, which was published in the Annals of Internal Medicine, Cannell and his colleagues described the association of hypertension, hypercholesterolemia, and electrocardiographic left ventricular hypertrophy with an increased risk of coronary artery disease. And then they went on to say something rather courageous. They said, whether or not the correction of these abnormalities, high blood pressure, high cholesterol, or LVH, once they are discovered, will favorably alter the risk of development of disease, while reasonable to contemplate and perhaps attempt, remains to be demonstrated. In other words, just because we have identified a phenomenon which predicts disease does not necessarily mean that we should go in and try to fix it. Going in and trying to fix it may not necessarily prevent it. More science is necessary. So a number of large-scale clinical trials were done. Some were funded by the government, some were funded by industry, and these are examples of two of them. And these studies consistently showed that the treatment of high blood pressure with drugs led to a decreased risk of stroke, a decreased risk of and a decreased risk of mortality. And the results were remarkably consistent. When I was a fellow at the Framingham Heart Study, I remember the incredible excitement that Bill Cannell showed when the main results of the systolic hypertension, the elderly program trial was published. It was published in 1991. And that demonstrated that the treatment of isolated systolic hypertension with diuretics and beta blockers led to a marked reduction in the risk of stroke and death. And Bill said, well, this shows it. This proves it. This shows that elevated high blood pressure really is bad and that it's worth fixing. And I remember he also pointed out that hypertension used to be called benign essential hypertension, and we have learned that it is not benign and it is certainly not essential. Now, the story of hypertension is not over. There continues to be a lot of interesting work going on. These are the results of the Accord hypertension trial that was published just a couple of years ago. In this trial, patients with diabetes who had elevated blood pressure were randomized to get their blood pressure below 120 as opposed to below 140. The trial showed, to many people's surprise, that reducing blood pressure to a greater degree did not result in an improved outcome. And right now, we're funding a big trial called SPRINT. This is going to be a 10,000 patient trial in which we're taking largely non-diabetics as well as older people and people with renal dysfunction, and we're randomizing them to more aggressive versus less aggressive high blood pressure control to see whether or not this leads to improved outcome. Now, the point here of this high blood pressure story is that by engaging scientists, basic scientists, epidemiologists, translational scientists, clinical trialists, communities like Framingham, and the patients, the hundreds of thousands of patients who participated in clinical trials, we came up with an answer. We're not done yet. There's still important questions that have yet to be answered. We still have not figured out a way to get everybody's blood pressure under control. But think about the value of hypertension care that's being provided today compared to the value of hypertension care that Franklin Roosevelt got. There is absolutely no comparison, and it all happened because of science. Now, hypertension is one part of a larger story in cardiovascular disease. This is probably a graph that many of you may be familiar with, which is the rates of cardiovascular deaths over calendar time. At the time the Framingham Heart Study started in 1948, the country was in the midst of a major epidemic of cardiovascular disease. And cardiovascular death rates continued to remain very high until the late 60s and early 70s, when they began the rates of death began a precipitous decline, which continues through this day. Death rates continue to decline. And here, on this particular plot, we show a variety of major studies, including risk factors being defined in 1961. That's the paper that Bill Cannell published, along with a variety of other major trials that followed after that. In 2006, David Cutler, who is a labor economist at Harvard University, published a paper asking a rather provocative question, which is whether or not healthcare is worth it. Is healthcare worth the money? And part of this is he demonstrated, he took advantage of existing data to show that life expectancy between 1960 and 2000 had increased by 7 years in the United States. And 70% of that increase in life expectancy could be explained by reduced death rates from cardiovascular disease. Now then, in a separate analysis, what he did was he tried to figure out what were the factors that contributed to to those reduced death rates. And he essentially identified 3 major factors: high-tech medical care, low-tech medical care, and behavioral change. High-tech medical care would be coronary bypass surgery, acute myocardial infarction care, defibrillators, stents when used in the appropriate setting, pacemakers, that type of thing. Low-tech medical care would be treatment of high blood pressure, treatment of high cholesterol with drugs, and aspirin in appropriate people. And then behavioral change would primarily be smoking cessation. And what he argued was that all 3 of these, high-tech medical care, low-tech medical care, and behavioral change, contributed to the decrease in cardiovascular death rates. And then he made an important point, a point which may seem obvious to us, but yet is highly underappreciated. In all 3 cases, we have research to thank. It was research, it was science that contributed to high-tech care, low-tech care, and behavioral change, the discovery that smoking contributes to coronary heart disease. And so he then went on to show that the return on investment for biomedical research in terms of cardiovascular disease was something like 4 to 1, and that was after making lots of very conservative assumptions. Okay, that's a great story. The story of hypertension, the story of interventions to improve outcomes in cardiovascular disease, that's a wonderful story. Now we're going to take a look at some very different stories. So here's a story from last September, an editorial that was published in the New York Times that came on the heels of a publication describing the results of a trial of intracranial stents in patients who had suffered recent stroke or TIA. And this is what the editorial said. The stents had been approved for humanitarian use by the FDA in 2005. That approval was based on a 45-person trial that lacked a control group. Optimistic surgeons have since inserted the devices into thousands of people. Now, a rigorous controlled study of some 450 patients has shown that those who were simply treated with drugs and lifestyle changes fared better than those who got the stents as well. This case clearly shows the value of conducting rigorous controlled studies with enough patients to provide meaningful results. This is just the kind of comparative effectiveness research that the national healthcare reforms seek to promote. So based on essentially no data, this technology became widely adopted in clinical care. Very much in contrast to what happened with Bill Cannell when he was warning about the treatment of high blood pressure. And this is the results of the trial showing that there was a dramatically worse outcome among those patients who were randomized to receive stents as opposed to those who were randomized to standard medical care. Another story. This is for those of us in cardiovascular disease, this is a story that is well known to us. Back in the 1970s, it was discovered, 60s and 70s, it was discovered that people who had lots of ventricular premature beats on their electrocardiograms were more likely to go on and die suddenly. There was extensive work showing this. This is an example of a paper that was published in the mid-1980s. Patients who had survived myocardial infarction, who had depressed left ventricular ejection fractions, or who had lots of ventricular premature beats, were at substantially increased risk for sudden death. Now, in their discussion, the authors say the following: it seems reasonable to recommend antiarrhythmic treatment as a means of reducing post-infarction risk. However, no study has been done to show that antiarrhythmic drug treatment can reduce mortality after infarction. Our results do encourage the pursuit of further studies. A remarkable echo of what Bill Cannell said back in 1961. Yes, we see that we can predict a particular event, but that doesn't necessarily mean that we've arrived yet, that we should just go ahead and treat it. So anyway, the doctors were widely believing that antiarrhythmic drugs were good. This is an epidemiologic study that was done showing that over the 1970s and 1980s, there was a dramatic increase in the number of prescriptions that were written for antiarrhythmic drugs. And in this discussion, the authors write that in the late 1960s and 70s, there was a flurry of reports that antiarrhythmias and sudden death, and it became recognized that patients with ventricular arrhythmias are at increased risk for premature mortality. Antiarrhythmic agents were prescribed with the hope that suppressing ventricular ectopy would improve survival of these patients with heart disease. Well, the trial was done. The first major trial was called the Cardiac Arrhythmia Suppression Trial. It was performed in the late 1980s. It ran into a huge amount of resistance. Critics decried it as being unethical since it was so obvious that antiarrhythmic drugs were going to improve outcome, that it would be completely unacceptable to assign patients to placebo. Well, the trial was done, and to everybody's surprise, those patients who were randomized to receive antiarrhythmic drugs did worse. They did much worse. They had substantially higher rates of death. And I remember when this trial came out, people simply could not believe it. And then there was another trial and another trial and another trial, and they all showed exactly the same thing, which is that people who were randomized to receive antiarrhythmic drugs did worse. And in this case, the authors note that the suppression of ventricular beats alone in this population is not an adequate indication that a drug will be helpful in prolonging survival. This study emphasizes the need for trials with mortality endpoints. In other words, we need real rigorous science to inform our treatment. And now we fast forward 15 years later. The results of the sudden cardiac death and heart failure trial were published. This trial was funded by NIH. There were other trials that were funded by industry, and they were all quite consistent that in certain patient subgroups, defibrillators could reduce mortality rates in patients who are at increased risk. Drugs do not. In this particular case, the investigators tested amiodarone, and they found no benefit. Next story. 1993, William Peters, an oncologist who at that time was at Dana-Farber, published a paper on the use of high-dose chemotherapy in women who had metastatic breast cancer. What he did was he gave massive doses of chemotherapy, doses that were so high that he essentially wiped out their bone marrows, patients' bone marrows, and then he rescued them with an autologous bone marrow transplant. He compared 75 women who received this highly innovative therapy to about 80-some women who received what was then considered to be the standard treatment. And the results were quite remarkable. Those women who were treated with high-dose chemotherapy did much better. However, in his paper, he sounded an appropriate note of caution. This was an observation. That's all it was. It wasn't a rigorous trial. And so he wrote, "We believe that confirmation of these results in a prospective randomized trial is important before this therapy can be accepted for widespread use. Many new therapies, initially promising, fizzle. This treatment should only be offered at major centers and whenever possible into randomized comparative trials." Great advice. Same echo as what Bill Cannell said about hypertension, about what Dr. Bigger said about ventricular premature beats. Well, that's not what happened. He had a great deal of difficulty getting this trial done. He was able to secure funding from the National Cancer Institute to do the trial, but then ran into an enormous amount of resistance trying to get patients enrolled. And this was nicely described by Shannon Brownlee, who wrote the book Overtreated. She writes, "By the time that Peters had organized his trial, few women wanted to participate. It meant running the risk of not getting high-dose chemo, and many had read the newspaper accounts that convinced them that this was their only chance for survival. Their doctors often agreed. One transplanter pulled out a copy of Peters' 1993 paper. 'I don't even see how it's ethical to do a randomized trial,' he said." So the trial was done. and showed that there was absolutely no difference in survival among those women who were randomized to high-dose chemo as opposed to those women who received the standard therapy. And summarizing the story, Shannon Brownlee writes, "From the moment that Peters first administered high-dose chemotherapy until the first trials were completed, nearly 20 years had passed. During that time, hundreds of physicians practiced the unproven treatment. An estimated 30,000 breast cancer patients suffered through high-dose chemotherapy, only a fraction of them as part of a clinical trial. All told, the nation spent about $3 billion paying for it, while an estimated 4,000 to 9,000 women died not from their cancer, but from the treatment." Okay, so let's look at these stories. I've now told you 4 stories. Told you the story of hypertension and cardiovascular disease. Told you the story of intracranial stents, antiarrhythmic drugs, and bone marrow transplant for metastatic breast cancer. So in the case of hypertension and coronary artery disease, there was a broad spectrum of scientific activity that led to the development of effective interventions. And this went all the way from basic science to translational to epidemiology to clinical trials, wide variety of scientific disciplines. And in these cases, science-based care yields value, without a doubt. In the case of intracranial stents, antiarrhythmic drugs, and bone marrow transplant, the science was incomplete at best. In the case of intracranial stents, we were talking about one uncontrolled 45-person study. And on the basis of that, this became something close to a standard of care. There was hope. In the case of ventricular premature beats, we actually saw in the article that physicians were prescribing antiarrhythmic drugs solely based on hope, on the hope that the use of these drugs would prevent events. And some would also argue that there was a lot of hype here as well. And then, of course, this comes up to the question of value, and that's a rhetorical question. That the patients who received these therapies, intracranial stents, antiarrhythmic drugs, or bone marrow transplant, they certainly received care that had the veneer of being very high-tech and of being science-based, but was that care of any value? And it certainly wasn't. It was of negative value. So why is this? This is certainly a pattern that we see over and over again in the history of medicine, and in fact it goes back hundreds of years, that doctors have engaged in practices for which there is little to no evidence of benefit. And Peter Orszag, who was the director of OMB during the first 2 years of the Obama administration, before this he was the director of the Congressional Budget Office, and directed a report on the importance of comparative effectiveness research in the United States. In December of 2007, the CBO published a report calling for greater interest in comparative effectiveness research. And this is what Peter Orszag said. Only a limited amount of evidence is available about which treatments work best for which patients, yet current practice tends to adopt more expensive treatments even in the absence of rigorous assessments of their impacts. And this is certainly true. One of the speakers alluded to this morning. This is a nice analysis that was done by the folks at Duke and the University of North Carolina. What they did was they looked at all active recommendations that are put out by the American College of Cardiology and the American Heart Association, and they found that only 11% are grounded in what we call grade A evidence, multiple randomized trials, and 50% of the recommendations are based only on expert opinion. So this certainly bears out what Peter Orszag has to say, that doctors very frequently, in fact perhaps much more often than not, engage in practices that are not based on the highest levels of scientific evidence. But that doesn't really answer the question as to why this is happening. In a way, what Orszag is doing is he's providing a description. He is saying that there is this phenomenon, that it's out there, that physicians engage in practices that are not based on solid science. But it doesn't explain why. So what I'd like to do next is explore a variety of thinkers and their perspectives on why it is that we see what we'll call negative value care, or care that is not based on solid science. So here's one opinion. Okay, so this is an opinion that was voiced by Sharon Begley. She's a journalist and writes for Newsweek, and her explanation is that doctors hate science. This headline came out in February of 2009. This was right in the midst of the legislative debate about introducing comparative effectiveness into the stimulus bill. And she writes here, "Scaremongers warn that effectiveness research threatens the lives of Americans. It's hard not to scream," she writes, "when you see how many physicians, pharmaceutical companies, and medical device makers seem to hate science, or at best ignore it. These days, the science that inspires fear and loathing is comparative effectiveness research. Scaremongers have morphed effectiveness research into cost-benefit analysis. Effectiveness research will threaten lives as government decides who gets life-saving treatment and who doesn't. Senator Tom Coburn, who is himself a doctor, warned of the Soviet-style federal health board that will put bureaucrats and politicians in charge of our nation's healthcare system." You might attribute Coburn's rant to his small government ideology, but I say blame his profession, not politics, but medicine. Doctors have long resisted having science guide their practice. And there are lots of examples of doctors resisting science. And this is just a small list. Vitamins for prevention of cancer and cardiovascular disease, widely prescribed, widely promoted, and thus far every randomized trial has shown no benefit or in some cases even harm. Screening for prostate cancer, which at best has minimal benefit and probably has very little, and yet widely promoted. I mentioned antiarrhythmic drugs, hormone therapy for prevention of a variety of chronic diseases, including coronary artery disease. When that trial, the Women's Health Initiative trial, was underway, every effort was made to stop it. It was decried as being unethical and unnecessary. Back surgery, which Dr. Nash referred to this morning, and imaging for back surgery, which was also Dr. Hood mentioned this morning. Intracranial stents, which we just talked about in bone marrow transplant, and the list goes on and on and on of practices which were widely adopted, and when efforts were made to come up with, to perform rigorous science to determine whether or not these therapies were of actual value, these scientific efforts ran into major resistance. So one explanation is that doctors simply hate science, and that's that. And in fact, we've even seen cases in the literature where physicians have ridiculed science. This is one of my favorite ones. Parachute used to prevent death and major trauma related to gravitational challenge, a systematic review of randomized controlled trials. This was published under the Hazardous Journeys section of the British Medical Journal. I will read this for you because this is just great. As with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subject to rigorous evaluation using randomized controlled trials. Advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. We think everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. Now, this gets brought up every so often. You know, when I talk about the importance of randomized trials, and inevitably somebody will mention this. Of course, this is an example of the exception that proves the rule. When you're dealing with an intervention that has an enormous effect size, you don't need to do a randomized trial. The reality, however, is that the vast majority of interventions we do in medicine, probably well over 90%, do not have this kind of effect size, do not have the effect size of parachutes. And when the effect size is modest, which is what we see most of the time, the risks of confounding and bias are so severe that the only science that is going to yield a definitive answer will be randomized trials. And this is even true for a risk factor as important as hypertension. Okay, here's some more evidence of hating science. This was great. I got invited by a group called Excel Pharma. And they invited me to give the keynote address. This is just about, just this month, just this past month. They invited me to give their keynote address at a conference they were holding in Washington on CER evidence. And this is a long time ago. They invited me to give the keynote address. Can you talk about the NIH perspective? I said, sure, I'd be happy to. And then I got the brochure. And the brochure is really interesting. It says, CER Evidence Summit, counteracting the impact of generating comparative effectiveness research, winners and losers. So this is what I'm supposed to talk about. I'm supposed to talk about how we're going to counteract the research that we're doing. And what about all these losers? And it'd be kind of like talking about how we're going to counteract our business. So I initially was quite perturbed by this, and I said I really would appreciate it if you could change your tagline. And then I thought, no, actually this is great. Keep it. And I actually then wound up spending a good part of the talk talking about why we shouldn't be counteracting comparative effectiveness research. But it is interesting and telling that they made this comment. Okay, well here's another explanation, and this one is a bit both more benign but also more scary at the same time, and it has to do with the way we are wired as humans. This is Daniel Kahneman. Daniel Kahneman is a psychologist who won the Nobel Prize in Economics in 2002 for the work that he and his partner Amos Tversky did on human decision-making and human thought. And they described a variety of cognitive biases that affect the way we think and the way we make decisions. And one of the most important biases that he described was something that he called the illusion of validity. The illusion of validity essentially says that if I have a very small amount of information, and on the basis of this small amount of information, I can put together a story, and this story feels good, I'm going to go ahead and believe it and act as if it's true. And so he talked about how he saw this over and over again, how people would jump to conclusions on the basis of limited evidence. And he said this is a phenomenon that happens so often that he came up with a complex abbreviation for it called WYSIATI, which stands for what you see is all there is. So he says, you build the best possible story from the information available, and if it is a good story, you believe it. Paradoxically, it is easier to construct a coherent story when you know little. The less evidence, the better. Our conviction rests on a secure foundation, our almost unlimited ability to ignore our ignorance. And in another interview, Kahneman said that we are blind to our own blindness. And it is a phenomenon that we see over and over and over again. And think about the time that you want to prescribe your patient a statin, and the patient says, my next-door neighbor took a statin and got terrible muscle pains, and there is no way I'm going to take this. And there's the story based on a sample size of 1. But before we're too proud, let's think about the thousands of patients who received intracranial stents based on that tiny, uncontrolled story of 45 patients. So in 1974, Tversky and Kahneman published this paper in Science called Judgment Under Uncertainty, Heuristics and Biases. Biases in judgment reveal some heuristics of thinking under uncertainty. Heuristics are rules of thumb. And they described a whole variety of biases. These are 3 of them. The illusion of validity, which is what I just talked about, where one overinterprets stories that are based on small amounts of data. And in clinical research, one of the biggest problems we have are surrogate outcomes. We use surrogate outcomes, and we think that on the basis of a surrogate outcome, we can now explain the entire universe. So we think that because a drug can make ventricular premature beats go away, on the basis of that, we put together a story. We say, well, that is a valid story to say that the use of these drugs will prevent sudden death. And that's an illusion of validity. That's incorrect. Another is the law of small numbers, assuming that small samples reflect the real world. This is something that we, again, see over and over again. Look at particularly lower level medical journals. You'll see these papers that are based on tiny amounts of events. There were 5 primary outcome events, 20 primary outcome events, and on the basis of this tiny number of events, we come to these sweeping conclusions about whether or not a particular therapy or agent works or doesn't work. And then the third is insensitivity to prior probabilities. If we see over and over and over again that a particular strategy does not work, and all of a sudden a study comes along and says that it does, it's probably wrong. And this is what we refer to as Bayesian thinking. And what Tversky and Kahneman and a variety of other cognitive psychologists did was they showed that even people who are sophisticated, even trained statisticians, make these mistakes over and over and over again. It's the way we are wired as humans, and the only way that we can overcome this is to be really hypervigilant. Okay, now that's one explanation. So one explanation is that we are beset by a variety of cognitive biases. Now here's another explanation. This is a great one. This is, I don't know how many of you recognize this guy. This is George Akerlof. George Akerlof also won the Nobel Prize in economics, and he won it for his paper on lemons on wheels. He wrote a paper in 1970 called "The Market for Lemons: Quality, Uncertainty, and the Market Mechanism." This paper was published in the Quarterly Journal of Economics, and it starts with an interesting, the first couple of sentences are directly relevant to what we are talking about today. This paper relates quality and uncertainty. The existence of goods of many grades poses interesting and important problems for the theory of markets. And then he goes on to talk about the market for used cars. It's a fascinating story, and it works something like this. Let's say that I am a consumer and I'm thinking about buying a used car. Now, I know that some people sell their cars because they want to buy a new car, because they're into new cars. But I also know that some people sell their cars because they have problems and they want to get rid of them. So the good cars we'll call peaches, and the bad cars we'll call lemons. Now we'll say that a peach is worth $20,000 and a lemon is worth $10,000. My problem is that as a consumer, I can't tell the difference between a lemon and a peach. The cars look the same to me. The seller will buff the car up and make it very shiny, and I have, with my level of sophistication, I can't figure out whether this is a peach or a lemon. So since I know, however, that there's a good possibility that this car may be a lemon, I'm not going to offer $20,000. I might offer, say, $17,500. Now, let's suppose that I go to a potential seller. The seller, of course, knows whether his car is a peach or a lemon. Now, if I am the seller and my car is a peach and you come to me with an offer for $17,500, I am going to say, no way. I'm not going to accept your offer. But on the other hand, if I happen to know that my car is a lemon, wow, I'm about to get a $7,500 windfall. So yes, absolutely, I accept your offer. Now what's going to happen is that the consumer, and I'll step back and be the consumer and say, why is he accepting my offer? The only reason why he can possibly be accepting my offer is that the car must be a lemon, which means I'm coming down on the price. So now I'm going to come down to $15,000. And then this happens over and over and over again. And eventually what happens is that the only cars that are available in the market are lemons. And so what he describes is that the lemons are driving out the peaches. In other words, there is the bad goods are driving out the goods, the good goods, the high quality goods, because of a problem which he referred to as information asymmetry. The information asymmetry here is the seller knows how good the car is, but the consumer doesn't, and the consumer has no good way of figuring this out. Now, Charles Whelan, who is an economist at the University of Chicago, has taken this idea of information asymmetry and he uses it to explain a lot of what's wrong in healthcare. He quotes the Nobel Prize Committee that says that the market for lemons, that particular paper, was a simple but profound and universal idea. And then Whelan goes on to say that healthcare is plagued with information problems. Patients almost always have less information about care than their doctors do. Even after we see a doctor, we do not know whether we were treated properly. This asymmetry of information is at the heart of our healthcare woes. And in fact, what he then goes on to say is that what we have in healthcare is we have layers upon layers upon layers of information asymmetry. So patients, they cannot figure out whether or not this is high-quality care or low-quality care. They are beset by innumeracy, statistical innumeracy, just like most of us are. And so they just like if I'm a buyer of used cars, I might be more impressed by a used car that's very shiny and that looks nice. As a patient, I might be more attracted to care which is newer and glitzier and prettier. I want the most care, and I want the newest care. Doctors want to maximize their income and minimize the risk of lawsuits. Now, payers have a problem because payers don't really know how sick their patients are, so they're also beset by information asymmetry. So they want to do everything they can to minimize payouts. Technologies are advancing, and they're advancing very quickly. They're developing very, very quickly, and in many cases, they're expensive. Some technologies are wonderful. Defibrillators save lives. Coronary bypass surgery saves lives. And some technologies, on the other hand, are of no use or, in fact, are even harmful. Intracranial stents are harmful. And the problem is that throughout this whole system, information is lacking, and getting information is costly. And this is where science comes in, because the critical role of science is as much as possible to correct these information asymmetries and therefore enable more peaches to come into the market as opposed to lemons. Okay, so what do we do about this? How do we deal with these cognitive biases, resistance to science, information asymmetry? The way we do it is we embrace science, and we make science a critical core component of our healthcare culture. And this is a beautiful example of this. This is the National Marfan Foundation. The National Marfan Foundation represents patients with Marfan syndrome, and what they've done is they have partnered with investigators, with their membership, with patients, and with the NIH to promote a trial. This is a trial which is comparing losartan to beta blockers. And this is what they say, and they really mean this. The National Marfan Foundation does not recommend switching from a beta blocker to losartan as a way to manage Marfan syndrome until the trial is completed. This is because we do not know whether losartan is clearly better than atenolol for taking care of people with Marfan syndrome. Now, this is absolutely beautiful. This is shared decision-making. This is value in healthcare. What this says is, if we don't know the answer, if we don't know what the right thing to do is, let's all get together and find out. And the way to do it is through the best that the scientific method has to offer. Now, there are examples of this. We have seen this kind of thing before. A beautiful example of this is pediatric oncology. There was a time when 80 to 90% of all children with cancer in the United States were enrolled in randomized trials. That was the norm. It was the expectation. There is a hospital in Germany, the Munich Heart Hospital, where more than 90% of the patients who are enrolled in that, who are admitted to that hospital, get enrolled into trials or into some kind of active clinical study. And by the way, it's not only that they enroll their patients into trials and they do good trials and their trials have affected the practice of care, they also provide very high quality care. When you get cared for at the Munich Heart Hospital and you're enrolled into a trial, they're going to make very sure that you get all the drugs that you're supposed to get and that you get your procedures on time. And the reason why is because if you don't, it's a protocol violation. So it's not only that they have brought the culture of science into their care, but they also, almost as a byproduct, give the highest quality care possible. And we should think about embracing science in part as a public good. So this is an interesting idea, which is that science, and that includes basic science and some kinds of clinical science, is a public good. And a classic example of a public good is a lighthouse. A lighthouse is something which we can all benefit from as a group. Now, the economic definition of a public good is that it's something which is non-excludable and non-rivalrous. Non-excludable meaning that anybody can benefit from it. Sometimes we refer to that as the free rider problem, this is the reason why government has to pay for it. Because if government didn't pay for it, nobody would. And examples of public goods include a national defense, state police, parks, and it has also been argued by many economists that basic science and certain types of clinical science qualify as being public goods. Now, the implication of science being a public good is not only that we as a society and that government should support this, but also that we, being patients, should all participate in it, that we should be engaged in it, and that this should be not just an opportunity, but actually an obligation. So Zeke Emanuel and a couple of his colleagues wrote this interesting paper in JAMA a few years ago entitled "The Obligation to Participate in Biomedical Research." And they argue biomedical research is a public good. It's available to anyone, even if you don't contribute to it. Therefore, participation in research is a critical way to support this public good. Consequently, all have a duty to participate. The public good arguments implies that individuals should participate unless they have a good reason not to. Such a shift would be of great aid to the progress of biomedical research, eventually making society significantly healthier. Now, this may seem like a rather radical idea, that there's actually an expectation to participate in research. Not that we'll make it possible for you to volunteer. But in fact, the substrate for this may actually be there. This is a poll that was carried out by Research America, where they asked adults how likely it is that they would participate in clinical research if they were asked. And 75% said either somewhat likely or very likely. So there are a lot of people out there who would be perfectly happy to participate in clinical research were the opportunity presented to them. Next question. Has your doctor ever suggested that you participate in a clinical research study? Only 6% said yes. Now, this is, by the way, not a surprise. Less than 10% of practicing physicians have anything to do with the clinical research enterprise. Less than 10% of physicians have ever participated in clinical research. And participating in clinical research could mean enrolling one patient into a study. So what we have is we have an enormous disconnect in which most of our profession, almost all of our profession, is living in a totally different universe from the universe in which clinical research takes place. So let me summarize these thoughts by suggesting that the way we create value in healthcare is through science. As Betsy Nabel said, research is what provides the basis for progress. We have seen a number of triumphs, such as hypertension, coronary artery disease, I mentioned pediatric cancer. We have also seen a number of failures in which science was not properly incorporated into healthcare. And I gave you the examples of intracranial stents and antiarrhythmic drugs and bone marrow transplant. And the question is, why is this? Why is it that we have so many instances in which medical care is inherently unscientific? I showed you the article by Sharon Begley that suggested that the problem is that doctors hate science, and then suggested some other explanations. One is that we are beset by cognitive biases and information asymmetry. The way that we get around this, and we've seen examples where we've been successful with this, is to embrace science as part of our culture. Now, the idea that we have poor value in healthcare is not a new problem. This is something that's been argued about for a very long time. This is a book that was written in 1662. It was published in London by a Flemish physician named Jean-Baptiste van Helmont. And it's entitled Physique Refined, the common errors therein refuted, and the whole art reformed and rectified, being a new rise and progress of philosophy and medicine for the destruction of diseases and prolongation of life, written by that most learned, famous, profound, and acute philosopher and chemical physician John Baptista von Helmont. And this book could have been written today. This book goes on and on and on about everything that's wrong with medical care. And on page 526, he got to one of his favorite subjects, which has become actually one of my favorite subjects, and that's bloodletting. He was very upset with the fact that many physicians practiced bloodletting, where they would drain blood at a rate of about a pint an hour from patients who were sick. And this was based on the humoral theory of disease, that disease was caused by bad humor circulating in the blood. And so this is what Van Helmont said we should do about it. He said, come down to the contest, ye humorists. Let us take out of the hospitals or camps or elsewhere 200 or 500 poor people that have fevers, etc. Let us divide them in halves. Let us cast lots, that one half of them may fall to my share and the other to yours. I will cure them without bloodletting. But do you do as ye know. We shall see how many funerals both of us shall have. But let the reward of the contention or wager be 300 florins deposited on both sides. Here your business is decided. This is a call for comparative effectiveness research. And it's a call for a randomized trial. And he's saying, look, we don't know what we're doing here. Show us that your treatment actually has value. And this is based on something that can actually be measured, which in this particular case is funerals. Now, to make a very long story short, it took about 150 years until a trial was actually done. The trial was done. It showed that bloodletting was dangerous. It was ignored for another 100 years, and then eventually the therapy went away. What's also really interesting about this call for science and for using science to assess the value of healthcare is why we do all this. And he says this about a page later, and I think it's amazing because this is 350 years ago, and yet you'll see he's articulating the same policy and economic ideas and philosophical ideas that we're talking about today. O ye magistrates, unto whom the health of the people is dear, he's talking about this contest, this trial. It shall be contested for a public good, for the knowledge of truth, for your life and soul, for the health of your sons, widows, orphans, and the health of your whole people. That's what we mean by creating value through science. Thank you.